Love you.
Don't be scared. It's going to be fine.
In the UK, some 3 million major operations are carried out every year.
I'll be there with you all the time, okay? We'll look after you.
But some patients' procedures are so complex, only the best surgeons can perform them.
Everybody happy?
Okie dokie. As soon as the patient is on the operating table, their life is in your hands.
Addenbrooke's and Royal Papworth Hospitals in Cambridge are world-renowned for their pioneering techniques to treat conditions that few others dare to take on.
It's a bonkers job, kind of like something from science fiction.
But pushing the boundaries of modern medicine comes with great risk.
I've got to get this right.
Things can go wrong very, very quickly.
We've got a venous bleed.
You need to be able to accelerate from 10 to 100.
Don't pull, don't pull. Jesus, what's happening?
The surgeons bear the ultimate responsibility.
We have a problem. There's a big problem. Can you just stop talking?
When things don't go as well as they should, then you start to question, was it something you did?
I have operated with tears rolling down my cheeks.
Doing our job takes its toll, but being a surgeon shows you life is precious.
That's it.
Youth.
Come on.
Bravo. Woo! Happy days.
This is somebody's life, and it has to be done perfectly every single time.
Addenbrooke's is an internationally renowned university teaching hospital
That's it. Thank you very much.
and a centre of excellence for a number of specialities, including cancer. Ekpemi Irune is one of its leading head and neck cancer surgeons, treating over 500 patients a year.
My mother was in healthcare, and of course, lots of textbooks around. And I would often flip through the pages, and I started to draw the pictures of the heart and anatomy. I became very intrigued by structures on the inside of the body, and that's how I got interested in medicine. But there are still not enough female surgeons in the country. But I was encouraged to dream and to do whatever I wanted to do.
Ekpemi takes on challenging and complex cases. Her patient today has been cured of cancer, but the treatment has left her unable to speak or eat. "75-year-old farmer's wife Nancy was diagnosed with laryngeal cancer 2 years ago.
Had 20 sessions of radiotherapy. I actually sailed through that. But after the radiotherapy, they realised there was a narrowing in the gullet, that nothing was going down. It's frustrating.
The radiotherapy sessions have left her larynx, which contains her vocal cords, so badly damaged she can only whisper. And her esophagus, which takes food and liquid to the stomach, so severely narrowed, she's unable to swallow at all.
Hello. I'm going to take these in now, and I will start making the dinner.
Okay. I've been married to Nancy for 50 years, and she's very social and would go out quite a lot. But what has happened to her over this last 2 years, with no swallowing, the quality of life from that is pretty awful.
Not being able to eat or drink has had a huge impact on Nancy and her husband, Harry.
I love cooking, and I always prepare Harry's meals.
Good, good, thank you.
And sadly, he eats alone.
For 7 hours every night, Nancy connects herself to a feeding pump that takes liquid nutrients via a permanently placed tube known as a peg directly into her stomach.
I am a real food person. I really miss roast potatoes, roast parsnips, and puddings, and I love eating puddings. I could go out to dinner and just have 3 courses of dessert. Actually, I've told my grandchildren this. When this is over and I can eat, I'm looking forward to a salted caramel Magnum ice cream.
radiotherapy Nancy's had in the past has caused some scarring of the fibers around the esophagus, making it difficult for her to swallow. And so when she eats and drinks, things don't go where they're supposed to go.
Nancy's esophagus is so scarred and narrowed, food and liquid can't travel down it, so instead comes back up.
Now, if you look at this area here, you can see how when she swallows, she gets liquid pouring into her airway because it hasn't really got anywhere to go. That's a problem.
To give Nancy the ability to eat and drink again, her esophagus must be completely rebuilt. It's big and complex surgery. The esophagus sits behind the larynx at the top of the airway. ECPEMI will remove the damaged larynx, carefully separating it away from the neck without injuring the nearby major blood vessels and nerves. Then, with the larynx removed, in the space left behind, she can reconstruct a wider esophagus at the top. Using flaps of skin, muscle and tissue taken from Nancy's arm and chest.
It is a complex operation. There are risks: heart attacks, strokes, infection, bleeding. That is the trade-off that patients always have to consider, risks versus benefits.
You can text me if there's any bits and pieces.
Yeah, I'll do that, yeah.
And obviously thinking of you. With an operation of this size and her age, there has to be a substantial risk. But if she can get back to some better quality of life, that has to be a major, major factor.
Morning, how are you?
I'm good, thank you. Yeah.
Very good. So, have you got any questions you want to ask about the procedure?
No, I think you have explained it very well for me.
You're ready?
I'm ready.
Good.
Yeah, I'm ready. Right. Thank you very much.
In Theatre 20, ECPEMI and a team of 12, including anaesthetists, scrub nurses and throat specialists, are assembling for Nancy's operation.
Hi, everyone. Hi, everyone. Morning. God, no women. What's going on?
Now that you mention it, actually, yeah.
The reconstruction of the esophagus is so extensive, it requires a team of plastic surgeons, led by consultant Nick Segaran.
I'm still a fairly junior consultant, so for me, I still get nervous about the big cases.
Which arm did you want? Left. Left arm. Yeah, okay, good. All right, yeah.
They're the cases, when they go well, that are the most rewarding. They also have the highest rate of complications. I still find it quite a bit of pressure, actually.
Yep, thank you. All right.
To bring the patient down.
Please, yeah, thank you.
Put that round your profile. So in case I get lost. Having the operation means a great deal. A way of getting my life back.
ECPEMI and Nick anticipate a challenging day ahead. The radiotherapy used to cure Nancy's cancer has left the tissue and blood vessels in her neck extremely fragile.
Are you worried about vessels? I'm not worried about vessels.
You're not worried.
I mean, I'll stop.
That's because you don't need to worry about them.
Radiotherapy is our friend and our foe. It's had so many benefits for patients, but the problems it has for us are multitude. It makes the surrounding tissues difficult to handle and they bleed more. And then that makes patients more susceptible to infection and wounds not healing well.
Everybody happy? Patients who have had radiotherapy, there is an element of unpredictability. I have a responsibility to bring this person back to their family. Starting.
Alongside its expertise in cancer, Addenbrooke's is a regional centre for neurosurgery, carrying out over 100 operations in its 4 dedicated theatres every week.
Good afternoon, main reception. Hannah speaking. How can I help?
Consultant surgeon Tom Santarius specialises in removing tumours from the brain.
I find the brain by far the most fascinating part of the human body. It holds one's thoughts, memories, emotions, and really personality of a person.
Today, Tom is operating on a patient with a tumour that, if left untreated, could be fatal.
Okay, so this is an MRI scan.
His patient has a sphenoorbital meningioma, a rare type of tumour that's grown from the membrane around the brain into the bone of the eye socket.
Because of its location, the meningiomas can interfere with function of various nerves, and they control muscles that move the eye around and also bring information from the eye to the brain. You can see the lens of the left eye, a lens of the right eye.
The tumour is growing rapidly and is starting to threaten the patient's vision.
The tumour is squeezing the space for the eyeball in the eye socket and pushing the eye forward.
His patient is 36-year-old Gemma, a single working mother of 3 young girls.
Can you come and play on the grass? You can come up and play on the grass because there's some bird seed down there.
I've always had headaches, and they've always been quite focused around this part of my head. But in the last year, I've noticed that their intensity and frequency have become a lot worse. I thought the headaches were just caused because I sat in front of a computer every day. My instinct was telling me that there was something probably more to it.
The tumour was detected when Gemma was sent for an MRI scan.
I had my appointment with the specialists. I could see the tumour quite obviously, and being told that I'd have to have surgery. Which, sorry. That's when, yeah, I kind of just, reality kind of came to me then. Yeah. I haven't told the girls that there's a tumour there.
Careful.
They know I'm going to have surgery on my eye and that the doctor's going to sort it out. And that's the extent of what they know.
Gemma's mum, Vanessa, will look after the girls while she's in hospital.
It's a time as a mum you have no control. That's the hardest bit. What I worry about the most is losing her. And obviously, with an operation on the brain, things can go wrong.
The biggest thing for me is sort of being away from my children. But now I'm here, just kind of want to get in, get done, and get recovering.
Morning. Hi. Morning.
Hi.
How are you?
I'm good, how are you?
Good. Okay. So, do you still want the operation?
Yes, please.
Are you sure?
Yeah, I think so.
Yeah. Take more time to ponder about it.
No, I don't think pondering is necessary now.
You don't the pondering type.
No.
So we'll go to the theatre and do the team brief, and I'll see you then.
Yeah, and your hard work starts.
Well, you know.
Lovely.
See you later.
Thank you.
To access the tumour, Tom will perform a craniotomy, cutting out a window of skull around the temple. It's occupying the space between the brain and the eye, and has also spread into the sphenoid and frontal bones around the brain and eye socket. The tumour and diseased sections of bone will need to be removed, but without disturbing the nearby optic nerve and the carotid artery. Then, Tom must carefully cut out the tumour where it has invaded thin protective membranes, the periorbita around the eye socket, and the dura around the brain.
So you got a wristband on?
Yeah.
Do you have an ankle band on?
Yep.
Any damage to the structures around the tumour could cause blindness, loss of eye movement, or a dangerous bleed on the brain.
With patients as young as Gemma, there is extra consideration, particularly when one gets to know that she's a mother of 3 children and she has so much to give. Hi guys, shall we do the chemo? Morning. Let's do it.
First patient we've got, Gemma.
But leaving the tumour is not an option.
Even if the meningioma is benign, and given her young age, if left alone, it could grow relatively rapidly and directly threaten her life.
Anticipated operating time?
It's difficult to anticipate, but we have pretty much the rest of the day. Okay, perfect. Thank you very much.
Right, come in, please. So we've got some oxygen for you. I'm gonna take this mask off. We'll be here all the time looking after you, wake you up at the end.
It's an amazing amount of trust that you're placing with people that you don't really know. But I have every faith.
Just concentrate on your breathing. Think of something nice. Lying on the bench.
Everybody ready? Yeah. 1, 2, 3. Perfect. I've got the arm, better way. Okay. So is it okay to start? Yeah. Can I have a monopolar, please?
To access the tumour, Tom starts by cutting into skin and muscle on the side of Gemma's head by her ear.
Cutting burr now, 5 millimeters.
Before performing a craniotomy, removing a 5-centimetre section of skull.
Moving much more.
To expose the diseased bone around the eye socket.
Okay, can I have a 3 millimeter kerrison? With the tumor infiltrated bone. So this will all go.
The sphenoid bone is thicker and spongy because of the amount of tumour that's invaded it.
See, all the bone is abnormal here, so all this will go, so I may as well remove it now. See how different the bone is?
Yeah.
Okay, can I have the drill, please?
Using a steel-tipped drill that runs 5 times faster than a domestic drill, Tom must remove the cancerous bone, a millimetre at a time.
So, we're just behind the eye here. The drill is potentially a very dangerous tool. It could turn into complete carnage. Now we're coming closer to the epicenter of it, that's why it's bleeding more.
The tumour has distorted the anatomy, so Tom needs to drill away the diseased bone around the eye socket carefully.
It's a bit like uncovering Pompeii after it was covered by volcanic lava. You're dealing with a rough sort of earth and so on, but in the middle of it you have something fragile that you don't want to damage.
As Tom drills, he must carefully navigate between a series of sensitive structures, the optic nerve and carotid artery.
Well, the best thing that can happen is that we remove the tumour completely, but is surgery around the brain, and there is always risk to either not surviving the operation or becoming severely disabled. Okay.
Back in Theatre 20,
Monopolar.
the team have started the complex and intricate operation to help Nancy drink and eat again.
24, please.
In order to repair Nancy's narrowed esophagus, Ekpemi must first make space by removing her damaged larynx.
Give me a swab, please.
She starts by making an incision that runs from ear to ear to reveal the anatomy in the neck.
This operation is one of my favorite operations to do. It allows you to really open up the neck and you can see all of the structures. It's a very beautiful sight to see the anatomy. And each time I do the operation, I do think, God, I'm lucky to be able to do this.
Swab to me, please.
But Ekpemi has to be careful. The neck is tightly packed with delicate muscles, nerves and vital blood vessels that all need to be separated away from the larynx.
Careful, you're going to put a hole in that esophagus. Hold that. We want to try and save the vessels on this side, so be careful.
We're operating very close to the major blood vessels in the neck, the carotid artery and the internal jugular vein. We have one on each side of the voice box.
Don't traumatize the artery.
No. You really want to make sure you don't damage these vessels.
There's a bleeder there, isn't there? Come on. Use your forceps for me. Don't pull too hard. Pull too hard, I go through the vessel because she's so skinny.
It is risky between the great vessels in the neck, and so you've got to be careful.
Ooh, don't pull, don't pull.
Yep.
Yeah, otherwise we're in trouble.
But if you make your peace with the fact that it's going to be difficult and it's not going to be a walk in the park, then it's more about rising to the challenge.
Don't pull. I stick close to the esophagus. Swab to me. Thank you, well done. Okay, stop for a second.
It takes Ekpemi over an hour and a half working around these fragile blood vessels before she's ready to remove the damaged larynx.
And I want you to make the final cut. Beautiful, well done. That's it. You can see no evidence of tumor. Looks fine. Okay, great, thank you. Looks good.
With the larynx gone, Nancy won't even be able to whisper. Ekpemi will correct this in a later procedure by placing a man-made voice valve in her airway so she can talk normally again. For now, she focuses on making Nancy able to swallow.
Can you see that?
A normal esophagus is 3 centimeters wide. But Nancy's has been so damaged by radiotherapy, it's less than 1 centimeter.
You can feel the stenosis is tight. Template? Yeah.
Ekpemi makes 2 very shallow 4 centimeter long cuts to muscle on each side of the esophagus to allow it to expand.
Ease up. Thank you. Relax.
You have to be very exact when you do a myotomy. And you have to be careful that you divide only the muscle and you don't go through into the esophagus itself.
Don't pull too hard.
If you get a hole in the esophagus, it can be very problematic. You can get delayed healing, infection.
Okay. Now I want you to hold this and give me some tension, yeah?
If you get a really unpleasant infection, it can track right down in around your heart and your lungs. It's a bit of a nightmare for you and the patient.
That's it, just gently. Ease up. That's nice. The anatomy is quite beautiful, to be honest.
Ekpemi is ready for plastic surgeon Nick and his colleagues to take over.
Hi, how are you?
Now the larynx has gone, there's a 5 by 3 centimeter hole in the front of the esophagus.
Amazing, look at this.
They can now enlarge the top of the esophagus so food can pass down it again by rebuilding it with a flap of skin taken from Nancy's forearm.
You feel it's so thin, it'll be like a full thickness skin graft.
It's very, yeah, she's got very thin.
I mean, we don't want a full thickness skin graft.
Ekpemi is really motivated, really vocal. She tells you exactly what's on her mind.
Yeah, you want it thin, pliable.
Yeah. Well, as long as it's not just skin, then.
No.
Yeah.
I'll take it as thick as I can.
She cares deeply for her patients. She wants the very best for them. She's not afraid to tell you what she wants.
give us lovely function, and then
And then
I think
we'll have a pack over the
aesthetics.
top.
Yeah, exactly, exactly. Thank you.
To cover the hole in the esophagus left by the larynx, the plastics team will harvest a flap of skin and tissue from Nancy's forearm, together with a vein and artery. These blood vessels will be connected to an artery and vein in the neck, so blood can flow in and out and keep the flap alive. And a second section of muscle, this time taken from Nancy's chest, will cover the whole site to make it watertight. Finally, as the removal of the larynx will leave a gap between the top of the airway and the throat, Ekpemi will bring it forwards and into a hole, or stoma, she makes in the neck, where Nancy will now breathe through.
I get a wet swab cage.
Such a complex and intricate reconstruction requires 3 plastic surgeons to work side by side. Nick's colleague Amir Durrani begins to prepare the vessels in Nancy's neck, where the forearm flap will be plumbed into.
Okay, give me the clamp a minute, please, for this. Looks like there is the branch of the IJ here that may be usable. Okay, it was encased in all this horrible scar tissue.
Damage caused by radiotherapy in the neck is making it difficult to find vessels good enough to use.
I don't want to dissect too much because it's really all stuck down.
At the other end of the table, Nick makes a start on harvesting the flap from Nancy's forearm that will be used to fill the hole in the esophagus. He begins by cutting a 5 by 3 centimetre section of tissue.
Let's centre it over there, I think.
Before he lifts out the flap, Nick needs to separate out an artery and vein connected to it. These will be plumbed into vessels in the neck, so the flap has a supply of oxygenated blood.
There's a pressure to preserve the blood vessels that are going to keep the flap alive. So that's always the most technically demanding aspect of raising the flap. If I injure either the artery or the vein, then the whole reconstruction is at jeopardy.
Nick wants to use the radial artery and cephalic vein. They're part of a bigger network of blood vessels supplying the arm and hand, so removing them won't affect Nancy's circulation.
Got it there? Yeah, I can release it here. You can go through that. Yeah? Yeah.
But Nancy's age means the vein is very fragile, and he's struggling to separate it out without damaging it.
Okay, usually the veins are massive.
It takes over an hour, but Nick has isolated the vein and artery, and he's ready to remove the flap.
Flaps off. That's a bit more tricky than usual, that. Yeah. Just worried that I was going to clobber it.
Now is the most difficult stage, connecting the flap vessels to those in Nancy's neck.
I'll get some micro scissors, please, Jax.
They're just 1 millimetre wide, so Nick uses a microscope, magnifying up to 15 times, to make the joins.
Everyone knows that when the microscope's out, it's almost game time, if you like, because the success or the failure of the operation, a lot to do with it is on the microsurgery. If you do it well, it won't cause any problems. If there's even a stitch off, and that can close off the entire vessel, and then blood will not be able to flow out of the flap. That's a big problem.
That's the vein, isn't it? Where's the artery? Yeah, good lad. Yeah, there.
Nick starts with stitching together the artery from the flap to the artery in the neck.
The stitching together of the blood vessels using a thread that's thin as a human hair is probably the most intense part of the operation, and you'll notice that it's a bit more quiet in the operating theatre.
Double clamp out.
It's all right. Flaps on.
Flaps on. Flap on.
That's good. Thank you.
Blood is flowing into the flap through the connected arteries. Nick must now join the veins so it can flow back out.
It's massive, it's not draining.
No.
Is it?
No.
Blood should be draining out of the flap via its cephalic vein, but it isn't.
If a flap doesn't drain, then it's at risk of failing.
So it can have massive implications on recovery and function.
And the whole reconstruction has to go in the bin, and we have to start again.
Both Nancy and I have discussed the possibility of a major downside. The news I would dread is if there was an early phone call. That would make me concerned. I would be anxious until I get the call that all has gone well.
In Theatre 22, neurosurgeon Tom Santarius is 5 hours into an operation to remove a tumour from 36-year-old Gemma. He's drilling away diseased bone in the skull in a 3-centimetre space between her eye and brain. And within millimetres of delicate nerves and the carotid artery, a vital vessel that carries a pint of blood to the brain every minute.
I always think of internal carotid artery as a cobra, not least because it's windy, it has a very venomous sting, so it's best to left alone. It is a large artery with a lot of blood flowing through it every second. And if we cause the rupture of the artery, there will be tremendous amount of bleeding. A stroke could occur. That's perfect, that's good, that's great. That's very good.
After meticulous drilling for almost 2 hours, Tom has avoided the carotid artery and removed much of the diseased bone.
I think you start seeing some light at the end of the tunnel now.
Now he needs to tackle the other 2 places the tumour has grown, the protective membranes around the brain and eye.
In order to cure Gemma of the tumour, we will have to remove every little bit of the tissue that contains the tumour, if we can. Actually, no, can I have a Mayo scissors? Thank you.
First, he must carefully scrape away the tumour from the periorbiter, the membrane around the eye socket.
Periorbiter is like an envelope around all the contents of the eye. It contains the eyeball, eye muscles, eye nerves, and everything else around it is padded by orbital fat. Big wash now. Okay, let's tie it up here, and then let's have a look at the orbit. To me, every little bit of the tumour that I can remove is worthwhile. Never give up, huh?
Oh yeah, it's coming, yeah. Alright, it's come out nicely.
It's actually not bad.
Yeah, it's come off, right?
With the tumour around the eye removed, now comes the most dangerous part of the operation. Tom must remove as much of the tumour as possible from the 0.5 millimetre thick dura, the protective membrane that surrounds Gemma's brain.
See a bit of meningioma here already. So we have a second, that's good. Can I have a hook and knife, please?
Yep.
Thank you. Okay. Anything that requires force in a neurosurgical operation is not right. Neurosurgery has to be gentle. Actually, no. Can I have a Mayo scissors?
As a 7-centimetre wide section of the diseased dura is cut away, Gemma's brain is exposed.
Yeah, you always kind of rest on the dura more than the brain. Just go in there. Let me direct you.
Oh.
Okay, second. Right or wrong? In everyday life, I'm very impatient. I can't stand really waiting for everything, but I suppose being in the operating theatre and doing brain surgery, I make myself as patient as required. I will not give up. Patience is the main name for neurosurgery. That's fine. I think we're done. I don't think we can make it any better. So I'm actually quite pleased.
After 9 hours of surgery, Tom has removed all of the tumour from the skull and the membranes around the eye and brain. For the operation to be a success, he must now repair the brain's protective layer and reconstruct her eye socket.
To perform the reconstruction after many hours of surgery does require extra focus and motivation. I'm very much aware of what the risks are and what the failures could be, but failure just is not an option.
Operations like Gemma's are a massive assault both physically and mentally. So much so, some surgical patients need intensive care, where their first days are critical. But a surprising and significant threat to their recovery is delirium, a severe state of confusion. At next door's Royal Papworth Hospital, they've constructed an intensive care unit designed to help staff treat the condition. Opened in 2019, the hospital's critical care unit has 46 single rooms, more than half for post-operative patients.
Patients that have come straight from theatre, they've got tubes everywhere, drains, infusions of drugs running. It's pretty full on.
As many as 80% of intensive care patients experience delirium, which can develop just hours after surgery.
Delirium is altered mental state. They tend to not know where they are, not know what time of day it is, why they're here.
Staff take it very seriously. Patients with delirium have longer recovery times and are more likely to die in the months after discharge.
We check every day to see if our patients have delirium. We have a scoring system, asking them simple things such as, does a stone float on water? Are there fish in the sea? Maybe ask them to squeeze your hand when you say the letter A, if you're spelling out a word. And that helps us identify if patients are delirious.
A known way to reduce this confusion can be difficult to achieve in a busy 24/7 ICU. Daylight to support a patient's body clock and uninterrupted sleep.
The new Papworth Hospital building helps immensely. We have natural light in every single room, big windows. We try and establish a day-night routine. We ensure that we've got the daylight coming through the window in daylight hours, and equally at night time we'd have the curtains closed, and we have the option of reducing the noise by closing the doors. We have the clocks on the wall that patients can see, so they always know what time of day it is, and just encourage sleep. Hey Jodie, how you doing? You had a good day today so far?
But whether a patient has suffered delirium or not, the biggest difference to a good recovery is the one-to-one care.
And you feel okay otherwise? You get to know them very well, and you know, sometimes you end up singing with them at the end of the shift. You gradually build up this bond with them. You really go through it together, in essence. Everybody here has got everything crossed for you.
Everyone's rooting for me, so many people.
I love this part of the job. They're going through a massive operation, and we get to be there, holding their hand, getting them through.
Back in Addenbrooke's Theatre 20, the team of plastic surgeons are having difficulty with the flap of tissue they need to reconstruct Nancy's esophagus.
And I get a small single clamp.
Plastic surgeon Nick must connect blood vessels from the flap to those in the neck, so it has a blood supply.
I mean, the cephalic is doing absolutely nothing, isn't it? Agreed?
Yeah.
So that's out of the equation.
But the main vein, which will allow blood to flow out of the flap, isn't draining, so can't be used.
When things don't go quite right, you have to remain calm. That can be difficult.
To be a good plastic surgeon, you have to have an open mind, a problem-solving approach to complex problems. It's absolute paramount to have multiple, we call them lifeboats in plastic surgery. So if one option's not working, we have to go to another and then another.
It's definitely VC dependent, isn't it? Microsuction, please.
To save the reconstruction, Nick's only option is to use two much smaller vessels in the flap, called vena comitantes, or VCs. But these are just 1 millimeter wide, 4 times smaller than the vein he wanted to use.
Two small VCs.
Yeah. I think I'm going to have to...
put this one on.
I'll put that one on. One's draining and one's not there, isn't it? Was the other one not draining at all?
No.
Nothing?
Yeah, nothing. It's surprising.
Nick can see that one of these vessels is not draining. If the flap has to rely on a single small vein, blood flow will be restricted, putting the reconstruction at risk.
Ultimately, the buck now stops with me. Any sort of problem or complication that happens, that's my responsibility.
Shall we put one on?
Yeah, and see what happens.
And see what happens.
Nick has no choice but to carry on and try and connect the only one that's draining.
You get a 3mm coupler.
Vein walls are twice as thin as artery walls, too thin to be stitched together. Instead, Nick uses a coupler to clamp them together.
Yeah, good.
It can be extremely challenging when you're under the microscope trying to attach 1 millimeter vessels. We're at our maximum point of concentration. Don't talk as much. More thought goes into our movements and how we are going to put those vessels together.
It is draining.
Isn't it?
You get a small single clamp. Tiny.
With one VC connected, Nick can return to try and attach the second one.
Got it? Yeah. Yeah?
Not yet.
Just
artery clip. This one, right?
Yeah. It's leaking. It's not hemorrhaging out, and that's all I want. It's fine, isn't it?
Yeah.
Finally, both small vessels are connected, and blood is now flowing into and out of the flap.
That's probably the best part of the operation, is when we take the clamps off and we can see the artery pumping blood through and the vein draining. Then you can start to relax a little bit.
I think Miss Irene can come. We're up for her.
Right. So how did the anastomosis go?
The artery was fine. Problem was that the vein that the flap was dependent on was small. So that proved challenging, but happy at the moment.
Good.
Now Ekpemi can stitch in the flap and rebuild the missing wall of the esophagus to make it wider so Nancy can swallow again.
Mastoid, please.
Perfect time.
Okay, so let's just look at the orientation. So this is like this, and I'm going to put it like this. Give me another 6.5, please, left hand.
Ekpemi must place 2 layers of stitches 1 millimeter apart. Any distortion to the shape of the esophagus could affect Nancy's ability to swallow.
Mastoid again, please.
It's important to get the stitching right. It is a combination of the space between the stitches, the kind of suture material, the layer in which you place your stitches, and the integrity of the knots you're throwing.
We're almost done now. We're almost done. Perfect, look at that. Spot on. Looking good. We're happy with the plan. Okay, let's raise the pec major.
Finally, a section of muscle the size of a hand is pushed up from Nancy's chest and sewn over the reconstructed esophagus to ensure it's watertight.
All good? Looking good?
Yeah, I think so.
Just the right length.
It is, isn't it? Just the right length.
Without the larynx, the top of Nancy's airway no longer reaches her mouth. So Ekpemi's last job is to reroute the airway to a hole in the neck called a stoma, which Nancy will breathe through after surgery.
Jackie, could we get a swab, please?
God, I'm bloody tired.
You do require some degree of resilience when you're doing head and neck surgery. Every part, right to the end, requires your full attention. It's not over until the patient is off the table.
You're literally closing and you're still looking at it.
I know. I know.
Stress. This is why I don't do plastics. Everybody okay there? You're happy?
Yeah, all looks fine, I think.
Good, so everyone's now
Yeah.
happy?
Yeah.
I think that's important.
The worry for me starts as soon as the last stitch is put in and we've closed the wound, because the next couple of days are critical.
Done. Nice.
The first night I tend to worry quite a lot. This all goes back to being a new consultant. Ask me in 10 years' time and I'll maybe tell you that I sleep really well on the first night. For me at the moment, that's not the case.
How are you? You okay? Good. It's all gone well. I'm going to give your husband a call. Okay. Thank you. Just support that. Thank you.
After 10 hours of meticulous surgery, Ekpemi and Nick must now wait at least 2 weeks to find out if Nancy is able to swallow again.
Just calling to say that the surgery went as well as it could. We just have to see how she heals and take it one day at a time. Okay, take care. All right, bye. Okay, happy days. The first stage is successful, surgery done, but we're not out of the proverbial woods yet. Nothing is guaranteed.
Such a bloody nightmare.
In Theatre 22, Tom is into his 10th hour of surgery.
It's torn.
He's managed to remove most of Gemma's tumour, but he's still got to repair the hole in the membrane around her brain, where diseased tissue was taken away.
Repairing the dura can be quite straightforward. In Gemma's case, the dural repair is not straightforward at all.
Careful, 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 careful. Oh, sorry. Mind what you're doing.
If Tom is unable to repair the dura, it will leave Gemma's brain exposed, which could result in serious infection.
This is just so painful. This is just so painful.
Tom is using a piece of manufactured collagen, 5 centimeters across, to repair the hole. But its soft texture is making it hard to handle and stitch to the thicker dura.
Discrepancy between the hardness of the suture and the softness of the material is just incredible, which makes it difficult.
Each stitch must be placed with great care, as Tom is working right up against Gemma's brain.
I need to be very much aware of the needle, its direction, the forces involved in propelling the needle in certain direction. So I must not allow it to move, flip, slip. It just needs to do exactly what I want it to do. And we'll get there. Okay, there you go. Right.
With the brain now safely sealed,
Okay, so, can I have the titanium now?
Tom needs to reconstruct the roof and sidewall of Gemma's eye socket where tumorous bone was removed. He's using titanium mesh.
To get the reconstruction right is important both from the functional point of view, i.e. that the eye moves appropriately without any double vision, but also from the cosmetic point of view that the eyeball doesn't sit too deeply in the eye socket.
The mesh is cut to size.
Think very carefully about it. One has to be quite exact in shaping the titanium to reconstruct the orbit. Pretty much like this and now, yeah? And you need to be able to fix it as well, so the roof, there's hardly any bone to fix it to, so. Yes, it requires one to be meticulous, but when one considers that it is the house for the eye, one needs to give it what it takes. Yeah, that's pretty close now.
It's screwed into place.
It's not bad at all. Okay, let's fix it here. Okay, can I have a pop-off, please?
Finally, the section of bone removed in the craniotomy can be screwed back into the skull.
So it also came together quite nicely. It's this, and that's it. Okay? Good.
After 11 hours, Gemma's tumour is out and the reconstruction complete.
Okay, on slide. Yep, she's waking up. On slide, ready, steady, slide.
Yes, please. This is just a normal way.
Hi, Gemma. Are you okay? It's all done. Went fine. Better than I thought, yeah?
Mark the extubation.
It will be several weeks before Tom and Gemma have the results back on the type of tumour and whether it's likely to return.
At the end of Gemma's operation, I feel more energetic than I would expect. It is, I guess, the adrenaline is still flowing, and we achieved what we wanted to achieve, or better, but you kind of always worry about what things can still go wrong. It's just the nature of neurosurgery.
Just 2 weeks after massive surgery to remove her tumour, Gemma is back at Addenbrooke's for a checkup with surgeon Tom Santarius.
So, how are things?
Yeah, really good, thank you. Pain is manageable.
It's still very early days, after surgery. Can you close your eyes and open them up again? And to wiggle your forehead? Yeah, you seem to be a very good healer.
Yeah.
So, the wound is really healing very well.
Have you had histology results?
Yes, I did.
Okay.
So I've got a couple of good news for you.
Okay, that's good.
So it is a grade 1.
Test results on the tumour show the chances of it returning are very low.
Also, the CT scan doesn't show any obvious tumour there. So that's good. So we'll have to see how it goes.
Yep, sounds good.
Good.
Okay, lovely.
Gemma, great to see you.
Angie, thank you so much for everything.
Yeah, very welcome, very welcome. It was a real pleasure to be able to share this with Gemma. And true joy to see Gemma's eyes lighten up.
Couldn't be any better, really. Big weight off my shoulders.
Go on.
Yeah, lowest grade. He says like 20% chance for it to regrow over 10 years. So stop worrying now. And so they'll scan me in 3 months and then probably a year then. So all good.
It's the best news possible.
Yeah, yeah. Bye, babe. I'm not having a sleepover, you Wally, this time. All right, I'll be home soon. Love you, bye.
Three weeks after major surgery to reconstruct her throat, Nancy is about to find out if after almost 2 years, she can eat and drink again.
Morning.
She's having a scan to see how her esophagus has healed
Very good.
and whether her swallow function has been restored.
And swallow.
As Nancy attempts to swallow dye, the scan will show if there are any leaks in her esophagus.
So we're just lowering it down to look more towards your stomach region, okay?
Waiting for the swallow test is always unnerving. And when the swallow test is done, I can't wait to jump onto a computer and pull up the images and have a look. So, good news, the swallow test has gone well. How do you feel? Great, fantastic. You can. What do you want? This? Oh, you're oh yes. Oh, you've got it waiting and ready. Oh wow. Okay.
With the test a success, Nancy can start drinking and eating again.
Let's have a go. Do you want to have a go? How does that feel? Good. Very good. Happy days. Well, it's lovely to see you. Take care. See you then. Okay. Bye. I can't imagine what it's like not to eat, especially because I'm a foodie. We forget how much of a ritual eating is. It's something that brings people and families together. To give Nancy back the ability to swallow and be able to eat and drink, that's a very rewarding thing indeed.
Nancy can now be discharged. She will return in 3 weeks to have a voice valve fitted at the top of her airway, which, with the help of a speech therapist, should allow her to speak again.
To have that coffee was lovely. I feel back in control. As you know, I did say ice cream, but this is better. I'm so grateful to Miss Rooney and everyone involved in my care.
If you ask most of the patients that come through our doors, quality of life is more important over the length of life. To restore quality of life is unique, and it's one of the things I enjoy about being a surgeon. I couldn't imagine being anything else.
Next time,
Okay, it's about to arrive.
the major trauma team
It looks a bit like a Formula One pit lane. Everyone has got a job to do.
where split-second decisions
Can we start?
are life-saving.
Fiddliest bit of the bloody operation.
As soon as these patients come in, the clock is counting down.
Can we get some hands?
My goodness, don't see that every day.
Personally, I think we're heading towards amputation.